Good evening, everyone. I am Ada, your moderator for today's Med Talk Digital CME powered by IGCP. It's a pleasure to welcome all our esteemed doctor and participants to this special session held as a part of Breast Cancer Awareness Month. Our topic for today is Unmasking the Lump, decoding breast clues every gynecologist must know focuses on a subject of immense importance as gynecologists understanding the subtle signs and early indicators of breast disease can play a crucial role in prevention, timely detection, and better patient outcomes. To begin this highly insightful session, I have the privilege to introduce our speaker, moderator Dr. Sharda Jan ma'am. She is Senior Consultant and Obstetrics and Gynecology Department Director in Life Care Center and Life Care IVF. Dr. Sharda Jan ma'am is a true pioneer and guiding force in the field of women's health. Her leadership and dedication continue to inspire countless clinicians across India. So, without further delay, let's hand over the session to our esteemed moderator and speaker, Dr. Sharda Jain ma'am, to take us through the discussion. Over to you.
Thank you, Ada, for giving me this national platform for a very, very important topic. October is the month of breast cancer awareness. And we find, as far as breast cancer is concerned, it is number one cancer as far as the woman cancers are concerned. Uh, we find that every 4 minutes, the woman is diagnosed to have a breast cancer, and every 13 minutes, a woman dies of breast cancer. As far as the Globocon 22 says that almost more than 2.3 lakhs cases, new cases are found in every year. Out of that, 50% are lost. The lifetime risk for breast cancer for Indian women is 1 in 22. We find that 60% of our cases come late in stage 3 or stage 4 disease, and which is in contrast with less than 30% in developed countries. At the same time, we find that nearly 30% of our patients are less than 40 years, and which in the Western world, there are only 5 to 7%. Another thing which I want to highlight is aggressive biology of our breast cancer cases. Triple negative patients are seen much more now in a younger generation, and that makes the prognosis bad. I will talk about the mortality incidence ratio. In India, it is 0.5%. It means 50% patients are lost. While in the Western world, it is 0.2%. That is 20% mortality is there. So to talk on the topic is very good. It is decoding the lump. Dr. Divya Singhal, who had been a past president of Delhi Gynecologist Forum North. She's also the national coordinator of breast cancer awareness from Foxy. She's also the chairperson of breast committee of, as far as the North India Gynecologist Forum is concerned. She's attached to big hospitals in the north here. We have expert today, Dr. Sneha Luhyar. She is again decorated gynecologist from Maharashtra. She had been the past chairperson of breast committee of Fox is concerned. She is has a she had been a participant of the Indian College of Obstetrician Gynecologists in past, and very active academician. She has been involved in the Maharashtra Society, which is a very large society, and she takes care of emergency care. And she's one of the very sought after speaker, both for national and international congresses, and that's why she's highly decorated as far as the laurels as of academic activity is concerned. She has a very special interest in breast cancer, and she'll be making expert comments after the talk of Dr. Divya Singhal. So over to you, Dr. Divya Singhal.
So thank you, ma'am, for your kind words. And madam, thank you for giving me this opportunity. I'm really fortunate today that I have two mentors with me as experts. Madam is my mentor and guide, and Dr. Sneha Bhuya has always encouraged me and motivated me. So, Ada, can I have my slides, please? Next slide, please. So we're going to talk about unmasking the breast lumps. We start with a quote from Michelle Obama, who says, "There is no limit to what we as women can accomplish." Well, there is no limit to what we as gynecologists can accomplish. The next slide, please. So why do we want to know anything about breast lumps? Next slide. Because every 13 minutes, a woman loses her life to breast cancer in India. For every two women diagnosed of breast cancer in India, one woman dies. Out of 100 women with breast cancer, 20 are young women. As gynecologists, we are the primary point of contact for a woman who has a breast problem. Early detection and timely referral can save lives. Following the rule of three, which we're going to talk about very soon, is the best strategy to detect breast cancer. Aim is to screen for breast cancer all patients who come to the OB-GYN clinic. Next slide, Ada. So we're going to discuss three cases of breast lumps in different age groups, and let's see how we manage them. So here's a case of a young girl who's 20 years old. She's unmarried and she comes with the complaint of a lump in her right breast. She has had it since she was in class 10th, but now it is somewhat bigger and occasionally painful. There is no family history of cancer breast or any other cancer. So how are we going to proceed? Next slide. Well, there is this rule of three or the triple assessment algorithm, and it says the rule one is clinical assessment, which means we're going to take a good history and do a very good clinical breast examination. Rule two says that advise imaging, get an imaging done, that is either a mammogram or an ultrasound or an MRI as required. And rule three says that get a tissue biopsy done, which should be a true cut or a core biopsy and not an FNAC if indicated. So the triple test or the rule of three has protocolized the management of almost all breast lesions. Its sensitivity is approximately 99.6 in detecting breast cancer. Next slide. So we apply rule one to this patient of ours, this young girl, and we do a clinical breast examination on her. Proper exposure is required in privacy. Examination is done in supine and sitting position in a systematic manner. And always remember to palpate the axilla, the contralateral breast, and the supraclavicular area. Document the findings, which is so important in this medico legal era. Next slide. So, coming to the physical examination of the breast, the first is inspection. Inspect the patient's breast in the sitting position. Both the breasts are inspected for any asymmetry, any lump, presence of lump, inversion of the nipples, any discharge from the nipple, any change in the texture of the skin, the podi orange kind of texture of the skin. Ask her to raise her hand so that the lowermost fold of the breast can be visualized properly, and then we make her lie down in the supine position, and palpation is conducted in either a radial fashion or concentric circles or in vertical strips. Next slide. And of course, the axilla and the supraclavicular and infraclavicular lymph nodes are looked for. So, what are the red flag signs of breast cancer while doing a clinical breast examination that we have to look for? We have to look for asymmetry in the shape and the size of the breast, inversion or traction of the nipple, bloody or serous nipple discharge, hard irregular lump, skin retraction, erythema, tethering, or ulceration. Next slide, please. Well, in this case, the first rule was clinical breast examination, and we found a painless, unilateral, well rounded mass, which, of course, is the mouse in the breast. And yes, it is the fibroadenoma. So, do we finish our examination here and tell her not to worry since it's just a mobile, well rounded mass and tell her to go home? Well, we must follow the rule 2 also and confirm the diagnosis with an ultrasound. A uniform hypoechogenic mass is what is seen on ultrasound. It is more transverse than vertical, which shows that it is not malignant, and there is less vascularity on Doppler. Ultrasound is the preferred diagnostic modality in less than 35 years of age, but in case the patient is more than 35 years, then mammography is the preferred modality, and a well circumscribed hypodense isodense area is seen. Next slide. These are the images of ultrasound and mammography, how a fibroadenoma looks like. Next slide. So coming to rule number 3, do we do a biopsy on this fibroadenoma on a young girl? Well, let's find out the indications for core needle biopsy. If it's a good sized um, mass, well, say about 3 centimeters is a good sized mass, then is it enlarging? If it's enlarging, then we do a core biopsy. A complex fibroadenoma, a fibroadenoma beyond 35 years of age, and if there is a family history of cancer breast. So, how do we manage this case? We've done all this. Well, surgical excision indications are a rapidly growing mass, psychological distress to the patient, very important. Cosmetic reasons. These days, patients are so particular about what they look like, and what they want to look like. Suspected histopathology report, complex fibroadenoma, age beyond 35 years, strong family history of cancers. So, what are the cancers we're looking for in first degree relatives? We're looking for breast cancer, ovarian cancer, endometrial cancer, colon cancer, prostate cancer, pancreatic cancer. All these cancers share the same genes. So we have to ask for these cancers in first degree relatives. And if any one of them is present, then she comes under the high risk category. Is there any medical management for a fibroadenoma? Yes. Counseling and monitoring 6 monthly or 2 yearly with ultrasound. Some people have tried ormeloxifene and it does work. Next slide, please. Next slide, Ada. Ada, can we have the next slide? So, what are the newer modalities in management of fibroadenomas? This is the era of minimal invasive techniques. So, we have VAB, which is vacuum assisted breast biopsy and excision. It is a device which is guided by ultrasound to locate the fibroadenoma. The device has a micro morcellator which cuts and sucks out the tissue. All of the tissue is retrieved and sent for histopathology, and it is a very good technique. Then we have the radio frequency ablation, where the probes are placed with minimal incision. It uses high alternating current to heat and destroy the tissue. HIFU, high intensity frequency ultrasound, focused waves are targeted onto the tissue. Thermal energy results in tissue coagulation and thermal necrosis. The advantages, it's a non invasive technique, but the disadvantages that no tissue can be retrieved for biopsy. So, amongst all these techniques, VAB is definitely the best. Next slide. So now we come to case 2, where we find a breast lump in a young woman of around 35 years. So this is a case of a 35-year-old woman who comes with pain and a lumpy feel in both the breast, which seems to increase before menses. She's anxious and she wants to know whether she has cancer. On examination, both breasts are tender, no well-defined lump is seen. What is the diagnosis? Does it need any further investigations? Well, on the face of it, it looks like a fibrocystic disease. And usually, what we do is we counsel the patient, convince her that it's nothing much, and we send her back home with vitamin E or vitamin B. Let's see what further needs to be done. Next slide, please. Fibrocystic disease is the most common benign breast disease. It occurs mainly in premenopausal years, characterized by painful, lumpy breasts, swelling, a greenish yellowish nipple discharge. It is hormone dependent, probably due to estrogen dominance, not associated with an increased risk of malignancy, although certain types have a chance of developing cancer breast. So, if the histopathological findings show proliferative changes with atypia, there is an increased risk of breast cancer. Next slide. So, in this case, triple assessment of the disease is mandated. Cytology of the nipple discharge is not required. Rule 1 means we do a clinical breast examination where we found a rubbery like texture, mobile diffuse lumps are felt, there is mild discomfort and pain, and there is a greenish discharge from the nipple, axillary lymph nodes, and supraclavicular lymph nodes are not palpable. We go on to rule 2, where we advise an imaging. Ultrasound is the best modality here. It differentiates between solid lumps from cystic masses. But in case there is a solid component in the cystic mass, then definitely a biopsy should be done. So, rule 3 biopsy, no red flag signs, not required. Next slide. Next slide, please. So, what's new? Well, just a mention about liquid biopsies. It's an upcoming technique. It provides early detection through blood samples. It involves analysis of components in blood samples such as circulating tumor DNA and microRNA. Liquid biopsies offer minimally invasive means of obtaining valuable diagnostic information. So, this is just a new kind of information. Next, please. Next slide. Yes, management. So, coming to the management of this patient of fibrocystic disease, we have already done a systematic triple assessment, and we've come to the conclusion it is simple fibrocystic disease of the breast. So, we convince her and advise her for support of breast with a well fitting brassiere, a sports bra, NSAIDs are very should be prescribed liberally. We're usually very miserly about prescribing NSAIDs. Then there should be a decrease in the content of OC pills in case she's taking them. Vitamin E, evening primrose oil, GLA, fish oil, all these do help. Then drugs like SERMs or meloxifene again can be tried and it is helpful. As far as danazole and tamoxifen are concerned, they are used as a last resort since they have severe, if there is severe incapacitating pain not responding to the above management. Next slide. So now we come to a last case of a 50-year-old menopausal woman had menopause 2 years back, and she comes with the complaint of a lump in the left breast. She felt it a month back when she was traveling. It is painless with slight increase in size. What further history would you like to ask? Well, family history of cancers. Has she breastfed her babies? Is she on any medication for a long time, like which contain estrogen? What is a menstrual history, early menarche and late menopause? Both of them contribute to greater exposure to estrogen and more chances of breast cancer. So let's find out what the risk factors for breast cancer are. Next slide, please. So the non-modifiable risk factors are age. As we see, our patient is 50 years. This is the peak time for breast cancer in Indian women. Gender, females have it more often. Family history, we've already discussed in case there's a family history of breast, ovarian cancer, etc. Personal history, in case she's been smoking or she has alcohol or she doesn't walk, she doesn't exercise. All these things contribute to breast cancer, early menarche, late menopause, and BRCA1 and BRCA2 mutations. Then the modifiable breast cancer factors are risk factors: obesity, alcohol intake, hormone replacement therapy, combined OC pills. So, next slide. Now, we've examined this patient, we've done a clinical breast examination, and we find that there is a firm, non mobile, non tender mass. And so we come to the rule number 2, which is radiological imaging modality. Which one should we choose? Should it be an ultrasound, a mammogram, or an MRI? Let's see. Next slide, please. Well, what about ultrasound? Ultrasound can differentiate between a cyst and a solid mass. It can help us in guiding biopsies. It can also be a good guide in younger age group where the breasts are very dense, and also ultrasound is to be prescribed or advised in pregnant and lactating mothers. Next slide. But we must understand that mammography is the gold standard. It uses low dose amplitude X rays. Mammography being the gold standard method to detect early stage breast cancer before the lesions become clinically palpable. Mammography has helped to decrease the mortality rate by 25 to 30% in screened women, whereas when compared with a control group after 5 to 7 years. Randomized trials of mammographic screening have provided strong evidence that early diagnosis and treatment of breast cancer reduces breast cancer mortality. So, mammography is the prescribed imaging modality in case we are suspecting breast cancer. Next slide, please. And it's also used for screening. So, the mammography reports come in BIRAD scoring. So, BIRAD score 0 is something which we wanted to emphasize on. If there is a BIRAD score 0, it means that they have not been able to come to any conclusion as to what the mass looks like, whether it's malignant or benign. So, another modality should be used at such times. Either it could be an ultrasound or an MRI, and the rest we know that grade BIRADS 1 and 2 and 3 are usually benign. 4 is suspicious of malignancy, and 5 and 6 definitely. 5 is malignant tissue. Next slide, please. What about MRI? The indications for MRI is when the patient is BRCA1 and 2 positive. It also helps to evaluate cases of inverted nipples, problem solving investigation cases of equivocal mammogram. When there's a confusion, mammogram is not telling us anything, it's a case of BARAT 0. So then we take the help of an MRI. It helps to decide if lumpectomy or mastectomy is the line of management. And in axillary load malignancy with an unknown primary site, this is what one should has to actually advise. Next, please. So, what are the breast screening guidelines? It says the breast screening guidelines from American College of Cancer Society, from Canadian Society, all these recommend that from starting from the age of 20, self breast examination should be promoted monthly, just after the periods. Breast clinical examination should be conducted every 3 years, and after the age of 40, mammography screening should be advised annually. In case the patient is high risk, then mammography alternating with MRI annually should be advised. So, very, very important for our country to teach self breast examination, since mammography is limitedly, is not available to all. Next, please. How can we use artificial intelligence? Well, it has been seen that in a trial that about 20% increase in cancer detection was seen using the AI support compared with routine double mammography reading. Next slide. And what about biopsy? Well, we must remember that it should be a true cut biopsy, which is advised, or which is called a core biopsy. FNAC, which is fine needle aspiration cytology, is obsolete. What is the reason? The reason is that we get a better chunk of tissue and more cells to diagnose malignancy. Also, tissue can be sent for immunohistochemistry, which is very important these days to understand the management, to plan the management of the patient for cancer breast, as ER, PR, HER2, NEW, all these receptor status can be actually found out by immunohistochemistry. Next slide, please. So, the management of cancer for this early detection and early referral, this is what the gynecologist is supposed to do, and then the oncology team takes over, and then the options available to the patient are surgery, radiotherapy, hormone therapy, targeted therapy, chemotherapy, and of course, a multi pronged approach is adopted. Next slide. Suppose this patient who came to us was diagnosed with breast cancer at the age of 35 and she has no children till now. What do? We first send her to the IVF specialist for oocyte preservation or embryo freezing. So this is what the point was. Next slide. She only needs about 20 days to, the IVF specialist will just need 20 days or 15 days to collect the oocytes. Next slide. Next slide, please. This is the dual stimulation protocol, which is followed by the IVF center to retrieve eggs. Next slide. So, in conclusion, the take home messages. As gynecologists, we are the primary point of contact for a woman who has a breast problem. Early detection and timely referral can save lives. Most lumps are non malignant, but every lump should be seen with suspicion unless proved otherwise. Following the rule of three is the best strategy to detect breast cancer. Aim to screen for breast cancer all patients who come to the OB/GYN clinic. Next slide. So thank you for your patient hearing. Detect breast cancer, treat it, and defeat it. The fight must go on. Thank you so much.
Wonderful presentation, Dr. Divya Singhal. Highlighted all aspects, but I would like now my expert, Dr. Sneha, to make critical comments and emphasize to the people who are listening that, what are the points they should be taking home. Because our
Yes.
detection rate is late, 60% of our cases are late, and by 2030, we want 60% should come in stage 1 and 2. So, over to you, Dr. Sneha.
Yes. Thank you so much, madam, for having me here. A very good afternoon to all of you. Divya, first of all, I would like to congratulate you for including the case scenarios, the entire spectrum of breast diseases, how to tackle them practically. That was wonderful. Few messages you have already given for every case. Maybe just a few addition or just improvisation I would like to do. So whatever you have included in the triple algorithm, it's the history as well as clinical examination, and then the imaging, and then of course the tissue diagnosis. So history is very very important, as you remember that the family history, the personal history, and the medical history. So family history, the importance, everybody knows that yes, if you have a family history of breast cancer, you are very prone for having the breast cancer. If you have had breast cancer in the past, maybe you have already completely cured of the disease, but yes, still you have a chance for a multifocal malignancy in the other breast. And then of course the medical history, all of you know it so well. uh, I have already appreciated, yes, the non-modifiable risk factors everybody knows, and we have no, but the modifiable risk factors which you can work on it, and you can definitely improve your BMI, your fatty content of the body, and of course your diet and exercise, the lifestyle you can improve on. Smoking and alcohol you can cut down or stop on it. So all these things, the modifiable risk factors, very very important, you have stressed upon. When you are examining the patient, you have the you have to just make her stand in front of the mirror. Whatever, I will just say a sentence about self breast examination. Even though the western guidelines and say that the self breast examination has not reduced the incidence of mortality associated with breast cancer, but for a resource poor country like India, where women are totally negligent of their health as such, and of course, including breast, making them aware of their breast, that there can be any problem for which they should go to the doctor, that itself definitely reduces the risk of mortality, I would say. And it is not true for India. So whatever is said and done, we have to follow self breast examination, clinical breast examination, and then of course mammography is the gold standard. So you have taken up it very very well. Judicious screening, of course I will be talking it a little later, so definitely I'll be covering the entire spectrum. But as a breast committee chairperson, Divya, you remember that after every CME, we used to have a message for our audience saying that basically every obstetrician gynecologist should make a habit of examining the breast of every woman, whoever comes to them for whatever problems, whether it is ANC, PNC, perimenopause, even the relatives who are accompanying the patient. We should make them aware of their breast and their breast problems. We should make a point to examine if she has any abnormalities, get it evaluated, and timely refer the patient to the oncosurgeon or breast surgeon or surgeon. And maybe if she doesn't have any problem, just teach her self breast examination, how you should do, how you have already elaborated, post menstrually, every monthly. And then of course, if she finds any abnormality, she should report to her doctor. I think that's a very, very
Dr. Sneha, I
effective
just
way.
want
Yes,
to intervene here that,
yes,
we've been talking the self breast examination should be done, self breast examination and a clinical examination by the gynecologist, by the nurses is cost effective. But we still find that 10% people know what is self breast examination. And I think, we talk too much, but it has not really taken on as far the public is concerned. We've been talking
yes.
about mammography for a long time. Again, you find that the incidence of mammography in our country is not more than 2%, and rural area it is 0.2%. So आप उसके बारे में क्या कहेंगे?
Um, I think that's the irony of the situation, that whatever I mean, I always say what you mean and mean what you say. This should, everybody should apply this to themselves. I think that's the only solution. It's not only talk. You have to implement in your clinical practice. If you see our OPD paper also, we have, a diagram of breast, two breasts, right and left, and all the four quadrants, and we make a habit, even my assistant doctor will make a diagram of, if at all she has even fine nodularity, she will mark it there. So I think for me it's a 100% examination of all the women's breast. We in fact tell them that we don't charge you separately, just allow us to examine, because that is for your betterment. Yes, madam.
I just want to tell you that as far as people who are watching in Kerala and Tamil Nadu, 65% cases of breast cancers are picked up in stage 1 and 2. If those people can do it, why can't it there be in the north? This is what I wish to tell you, because WHO has given a guideline and goal for government of India that 60% of the cases must be picked up in stage 1 and 2 as far as 2030 is concerned. So I think guide people on that. And another couple of things, questions I want, what people are wanting about it. Tell them, if first degree female, if the relative has it, what is her chances, and what is the chances of BRCA1 and BRCA2 is positive, are there in the community. Just highlight on that particular point also, Dr. Sineha.
Yes, actually, BRCA1 and BRCA2, these are the genetic markers which we have. We actually, it's not to be done for every patient or her relatives. In fact, there are certain criteria for whom we should do BRCA1 and BRCA2 testing. If at all the lady has breast cancer at an age of less than 50 years, if she has a breast cancer in the age of less than 60 years, if she's triple negative, if her any of her male relative has a breast cancer, prostatic cancer, or colonic cancer. So all these are the criteria for whom we have to do the genetic testing. So now, why we should do the genetic testing? Because if these are positive, you have a very high, of course. But for BRCA1, it's the breast as well as ovarian cancer, and it is to the tune of 50 to 70%. That high is the chances for breast cancer as well as ovarian cancer. BRCA2 little less, that is 30 to 40%. But even when you are, BRCA1 and BRCA2 positive, now the discussion goes, if at all the girl or the lady is BRCA1 or BRCA2 positive, what should be the way of management, what should be her, because everybody remembers Angela, and so going for prophylactic mastectomy, but it is not so. Definitely, if you have a BRCA1 positive, you have very high chance for breast cancer, and you should go ahead with prophylactic mastectomy as well as oophorectomy. But what is the age, appropriate age? I remember Dr. Suchitra Panditan, we had a discussion, Dr. Divya. So the age is 35 years, 35 to 40 years. Before that, if you go for prophylactic oophorectomy and mastectomy, then only that gives you the protection. Now, it's not for everybody. You should go ahead with the testing and repeated surveillance, or what you say, timely surveillance. It's not for all of them that go for prophylactic mastectomy and oophorectomy, but at any point of time you have a high risk in the examination, definitely you have to go for the prophylactic surgical procedure. Yes.
The first degree relative, your mother has had a breast cancer or your mossy has had a breast cancer, public still does not know that she stands 2 to 3 times chances of increased breast cancer there.
Yes.
So, clear message you must give to the public what they want. And many people think there is no pain in my breast lump, so there is no problem. That also you must highlight what you should be telling these people.
In fact, Dr. Divya has already said that every lump in the breast is not cancer, but unless proved otherwise. So, first clinical sign I would tell my patients that, whenever you are actually pressing the lump, even, actually squeezing it is not painful. But there are certain even exceptions to this. There are many patients nowadays, even from the fibroadenosis. Here, there is a little area of confusion. Fibroadenosis or fibrocystic breast disease, once upon a time said to be purely benign breast disease, nowadays proven to be having 3 to 5% risk of having a breast cancer. And that is why a patient who's got a family history, who is elderly, having a child at a higher age, more than 30, not breastfed a baby, and having fibrocystic breast disease, should be subjected for FNSE, so that we keep a surveillance on her. So that is how you have to tell that painless lump basically is a culprit, that you have to keep it in mind. But family history, if she has even any fibroadenoma persisting after 35 years of age, any fibroadenoma which is in the category of phyllodes, also having atypical epithelial calcifications, and those who are called as giant fibroadenomas also, all these needs to be evaluated very thoroughly. And even fibroadenomas can land up into or turned out to be malignant in such patients.
Dr. Divya Singhal, these days, our poor country, still you find that the breastfeeding is not universal, something like 65%.
Yes. Yes.
What message you want to give? If you do breastfeeding, how you prevent your breast cancer? Dr. Divya Singhal.
Yes, yes, ma'am. In fact, breastfeeding has now again come up, and it is now there have been number of studies which have been done, and it is said that exclusive breastfeeding for the first 6 months and breastfeeding for the next 6 months, that is 1 year put together, can reduce the chances of that patient having breast cancer by 20%. So, breastfeeding is extremely important, not only for the mother, but also for the baby, as we all know. And for the mother, it also prevents ovarian cancer, it prevents hypertension, diabetes. There are so many other things. And for the baby, it actually brings about better cognitive behavior, better mental IQ, and it also prevents different allergies and cancers in the baby. So,
So
breastfeeding
the
helps.
message is very clear from Dr. Divya that if you have breastfed your baby for at least 12 months, तो आपका 30% चांस तो ब्रेस्ट कैंसर का वैसे ही खत्म हो जाएगा. Now
Yes,
the
ma'am.
question is, when the screening is so low, there is a no national screening there at the time. They are just predicting that आपके जितने भी आयुष्मान मंदिर हैं और जो NCD clinics हैं, उसमें किस तरह से screening होगी, उसमें भी थोड़ा highlight करिए डॉक्टर दिव्या.
So, ma'am, I would say that at least in our own clinics, we have to teach our own paramedical staff, which we are doing. And we also put up TV pay, we put on videos showing how the self breast examination is done, how important it is. And we tell each patient who comes, whether she's come for a pregnancy checkup or she's come for a menopause checkup or AUB or anything, we tell every patient what exactly a breast self examination will do to her and how it is so important, being breast cancer being the topmost. Besides that, we have to take over onto the media. This platform is so good, and we have to use our Instagram handles and Facebook, and we have to use all sorts of media to propagate this message.
See, by propagating message, you are creating an awareness, but it does not translate into examination. I've told you if we are at 10%, we have to scale it to 90% or almost 100%. I'm just giving an example of cervical cancer. Cervical cancer is in the country for some since 2008. Our in HPV cancer rate at this particular time is less than it. Government said 2 years back 3%. Now it says 2%. So कहने से कुछ नहीं होता. This is what I want to tell you. If Kerala has done it, if Tamil Nadu has done it, they have clinically shown कि ये करना है. खाली बोलने से कुछ नहीं होगा. This is what I wish to tell you. बोलने
Yes.
से कुछ नहीं होगा. आपको बताना पड़ेगा कि किस तरह से आपको उसको प्रैक्टिस में लाना है. आपको सिखाना पड़ेगा. When they see that you walk the talk, आप भी करते हो, आपकी नर्सेस भी करते हैं, सब लोग आपको करते हैं, तभी ये वाली काम होगी. If Kerala and Tamil Nadu can do it, why can't we do it? I think that's one thing is very
Yes.
clear. Everything on a
Yes.
high risk factor. I just want Dr. Sneha you to tell people what are the different type of cancers are there, which are bad prognosis or good prognosis. So like a triple negative or
Yes.
HER2,
Yeah. So
just in a very simple way.
yes. Basically, I'll just add to the previous question, if you allow me. Only one sentence.
Go ahead.
Basically, there is no organized screening for like cervical cancer, but it is an opportunistic screening, and we should make a habit or as a part of protocol of our examination that gynecological examination must include breast examination. How you go for
I'm talking, madam, I'm
yes,
talking on cervical cancer. I'm coming back again.
yes.
The government
So
has announced it 2 years back. Still, it has not taken. They know COVID example is in front of you. हम एक बार अपना पिटारा खोल देंगे तो हम we will see to it 100% are screen. But what about screening? What about the treatment of precancerous lesion? And that's why they are holding it back. The problem तो हमारी है डॉक्टर साहब.
yes, agree.
खाली कहने से कुछ नहीं होगा डॉक्टर साहब. We have to translate it. So this is what has to be there. The government is holding national immunization program. वो कहते हैं हम पैसा दे देंगे, वैक्सीनेशन तो हो जाएगा. आपने स्क्रीनिंग तो स्केल अप करी नहीं, वो तो अभी भी 3% है. So something has to be done. All of
Actually,
now,
the message here is
you have to tell about the triple negative and hers too.
yes. So basically, as you know, that the breast cancer, it can arise even not only in the glands, the lobules, but also in the ducts, and there are various types. All of you know, but then histopath type, I will not say. It's only the histochemistry, the chemistry, the ER/PR positive and negative. That is the estrogen and progesterone receptor positive and negative. If it is positive, the hormone therapy works well. So, in fact, being ER/PR positive is a good sign. Then comes the HER2. HER2 is positive, good, well and good. You can give Herceptin. If it is negative, there's no question. But if it is positive, you can give. But triple negative is the worst kind of malignancy because you don't have a definitive, sensitivity of the tumor tissue to any of the medications, and that's the very reason it can progress on its own. And neither the hormone therapy nor the Herceptin or that is trastuzumab works, and that is why this is the worst type of malignancy. And that is why, in fact, I have already said that malignancy at a younger age and having a triple negative malignancy has a poor prognosis.
There is a delay in biopsy. No, she has diagnosed there is a lump. There is a delay in biopsy. वहां पर ये where we have failed there कि आपने diagnose किया कि आपको ये होना है. But I think probably somewhere we have failed, that she does not go immediately for the biopsy. तो उसके बारे में कुछ आप कहना चाहेंगे? You make them very clear that FNAC का कोई मतलब नहीं है. Please, Sneha.
Yes. Let it be very clear that fine needle aspiration cytology. So aspiration cytology, the tissue, if it is a fluid, then only it can be aspirated and then it can be examined. If you have a solid tumor, basically So the cells are not aspirated, it's only the hemorrhagic fluid comes, though in some cases you can. So we have to be very, very clear that for a solid tumor, it has to be a true cut biopsy. It never should be FNSC. So FNSC, I think it should be
I think it should
totally
become a
a
history.
fluid.
I think you
Yes,
should say yes.
it should go, it should be reserved only for the fluids FNSC, and it had to be the true cut or the core biopsy. That has to be. And as you said, very rightly, it's not only histopathology but immunohistochemistry. So that is one more advantage, that even before the major surgery or the actual definitive surgery, you can get to know which kind of biopsy you are dealing with, including the pathological grade. Yes, madam.
I'll make a comment, and I want two of you just chip in for that. 50% of our cancer patients do not complete the treatment. 50% of our cancer patients do not complete the treatment. It may be because of the cost, it may be because of proper counseling, or she has, डर गई है वो अपने अपने treatment में. Now, question is mastectomy, when it is advised, it is denied by people. When she knows it's a cancer, it is denied by people. Again, the counseling effect. And finally, conservative surgery can be offered, as is offered in the West in 60 to 65% of cases. It cannot be offered in our patients because they come late. And that is why early diagnosis is must. Over to you, doctor. And the recurrence rate. After breast cancer, there is no guarantee it will not recur. The recurrence rate is highest among the in the
Very.
first 3 years. तो उसके बारे में भी आप comment करेंगे, both of you.
So, ma'am, I'd like to take up this question first. And the first thing is that as far as going to the biopsy, you've commented that the patient, we've diagnosed a breast we've made a clinical examination and made a diagnosis, clinical diagnosis, that it's most likely cancer, and we want to send her for a biopsy. So, biopsy can be conducted by the ultrasonologist or the radiologist. So, we have to go hand in hand. We have to actually teach our radiologists to go ahead and buy the core biopsy device and do core biopsies in under ultrasound guidance, or we can do it ourselves. Core biopsy is not a big major issue, and the reason why we should start doing core biopsies is because it saves time and the diagnosis can be made early. But of course there is a controversy whether we should do it or not. That comment is for you, ma'am. So now the next question is that she should be referred to the onco team as soon as possible, and whether a mastectomy should be done or not. I would say that a mastectomy is the preferred modality, and we should act as counselors. As soon as the report of the biopsy comes in, she comes back to her gynecologist because we have sent her for the biopsy, and she asks her, now what? And she's so scared, and her whole world has come to a standstill. So we are at that time her motivators, her counselors, and we tell her, stage 3 tak you don't have to worry at all. In fact, even stage 4 these days is curable. So there is nothing to worry. You just have to go in for the treatment, and then you'll come back with and lead us very strong second innings life. And we've seen so many breast cancer survivors becoming better and stronger women and more empowered. So therefore we have to act as counselors, and
Divya,
we have.
Divya, Divya, there are national figures, and I repeat again, 50% do not complete the treatment. Now I'm coming to the last question because we have only 5 minutes left. Gynecologists are the first touch point. What message, Sneha, you have it for them? You already said that in your own practice, you see to it that
Yes.
you talk openly about the breast. You
Yes.
always examine these patients. Any checkup, antenatal, gynae, any patient,
Yes.
anything,
Yes.
you do not miss the diagnosis of breast cancer, and you teach your nurses also to do the same. आप
Yes.
क्या मैसेज देना चाहेंगी to the all gynecologists, all nurses, all lady
Yes.
doctors?
To all the gynecologists, obstetrician of this country, I would like to again urge. I have been talking to all of you since last maybe 5 years. Every CME we used to give this message, saying, but I think it's a high time that we implement it. the gynecological and obstetric examination should include, or must include, I would say, the breast examination, how we include the internal examination, and how we should take up also the pap smear and VIA, VILI as a part of gynecological examination. So these are the two killers of our women. So we, I have been always saying that we save our women to these dreaded obstetric complications, and we lose them to these deadly diseases. So we should be, we should do justice to ourselves and our women. Please do include breast examination as well as complete internal examination and screening as a part of your routine examination. I mean, not to say that how what I do, but yes, all of us should do this. That we should follow. That all our assistant doctors and nurses also should know that we make a format that right how we do pulse, BP, etc. Breast examination, internal examination, pap smear, mammography. We write it as a, in, if you have the software, we write in the software, we have it in the print also, that yes, as ultrasound, pelvic ultrasound, mammography, blood investigations, and of course the pap smear, all these things have to be there, or to be performed as a part of your gynecological examination.
So we say healthy breast, healthy woman, healthy Bharat. Doctor, what is the pink pledge, doctor, you want everybody to take, Dr. Divya? Pink
So,
pledge. Again,
okay.
same thing. Boliye?
So each patient, each person, each woman should be able to do a breast self-examination and learn it from the gynecologist and teach it to other people whom she meets, her own relatives, her friends. So that this is the breast pledge from my side.
I think it had been a wonderful breast awareness. Everybody who's listening, whether they're doctors, nurses, lay public, breast cancer has become the number one cancer. And it's very unfortunate that a 50% mortality is there, because 60% or 70% of our patients are coming late in stage 3 and stage 4. So any lump in the breast should be thought as cancer unless proved otherwise, whatever your age may be. You have to go and see the doctor, then only you will come to know whether it is not cancerous. You should think, if I have a swelling in my breast, it can be a cancer. So I think with that particular note, whole of October month has been kept for breast cancer awareness. There are days only fixed for one particular condition, but it is whole month has been given to breast cancer awareness. I think there must be meaning into it, international as well as national. So I want you to just make last minute one sentence comment by Dr. Sneha and by Divya.
I would say, why only blame the government? Be a responsible
No, no, we
citizen,
have to be
be a
blamed.
responsible gynecologist. We have to do justice to ourselves and to our women. So get screened yourself and screen the patients. I think that should be the
Dr.
message from me.
Divya.
Thank you.
So my slogan is in Hindi. It says, एक सीखे, एक एक सिखाए, स्तन कैंसर को दूर भगाए। सब लोग ब्रेस्ट सेल्फ एग्जामिनेशन करना सीखें और दूसरों को भी सिखाएं।
Yes, it is to one 1-to-1 आपकी काउंसलिंग होनी चाहिए। 1-to-1 आपको टीच करना चाहिए कि कैसे काम करेंगे। बट एक गायनोकोलॉजिस्ट को 100 गायनोकोलॉजिस्ट, 100 लेडी डॉक्टर्स, 100 नर्सेस को सिखाना पड़ेगा, तभी ये काम होगा। देन ओनली विल बी केरला और तमिलनाडु। So thank you very much. Having you here, there'll be many more programs as far as breast cancer awareness cancer is concerned this particular month. So thank you, Med Talks. Thank you, everybody.
Thank you,
Thank
ma'am.
you.
Thank you,
Thank you,
Mentor.
madam. Thank you so much. Thank you.
मैडम आदि तो पता नहीं कहाँ पर है। चलिए।